Welcome to IBD TV. My name is Dr. Karen Croker and I'm one of the adult gastroenterologists that work at the University Hospital in Edmonton. Today we have with us Dr. Matt Carroll. He's an assistant professor of pediatrics who works with children with IBD. And this is Dr. Hin Nguyen, who's the associate professor and director of pediatrics at the Stollery Hospital here in Edmonton. And so today we're going to talk to you about IBD care, transition care for teenagers. So first of all, I want to talk about is that transition care, what is it? So transition care is actually a process by which children are transitioned from pediatric care to adult-oriented health care. And so it's different than actual transfer of care. So transfer of care kind of happens in the middle of this, where the pediatric doctors would transfer to someone like myself, patients that are about to turn 18. And so transition actually takes place before and after that care, because we know that there's some things that people are all different and unique, and so that there's things that need to happen for you to become mature in managing your own IBD. And so this is a diagram that we've put up where there's actually, you can see that it's a transition. Your care is actually a continuum, which is the bottom on the bar on the bottom. And at the top you can see that pediatrics takes care of you for a first part of your life. And then as you become an adult, your care gets transitioned and we take care of you there. So I'm just going to turn it over to Dr. Carroll, who's going to talk a little bit about what patients should expect from transition care and what that would mean for you.
Thank you, Dr. Craig. So as mentioned, transition it's a process. It's not a defined date or a defined point in time. Rather, the actual transfer of care is something that we can identify and say, well, this is one clinic where you start now with the adults. But the general process is something that occurs over a period of time. And it's actually very hard to answer the question that is often asked, which is, when do I transition? Because in a perfect situation, it happens when everything is set up and everything is ready. So as you can see on the slides there, it happens when our patient is ready, our young adult. It happens when their parents are ready, and that can sometimes be a very challenging process for parents also. It happens when the disease itself, when the inflammatory bowel disease is in a situation that we can safely transfer and not have things fall apart. And then also, as key players in this, it happens also when we're in a position to be able to transfer care across to the adult service. So for our adolescents and our young adults out there who are watching, one of the things that is important to recognise for when you're ready is the fact that you've taken on some level of responsibility about your illness, your Crohn's disease or your ulcerative colitis, and the fact that it's something that is affecting you. It's not affecting your mum and dad necessarily. These are questions that we ask about you. It's your body and you need to be able to speak up for yourself and answer questions for yourself. We want to know what's important to you. We also want to know that you understand what's going on with your body and what medications you're taking. It's very important that you've taken on that responsibility of actually looking after medications. When are they due? Do you get up every day and take them yourself, or does mum and dad have to keep reminding you? We also want you to be a very important part of the discussion and the decisions that are made regarding how we treat you. When you're younger, 5, 6, 7 onwards, it's largely decisions that mum and dad will make on your behalf. As you get older, though, you have a greater and greater say and influence about what goes on, and it's important that you take part in that process. And it's also important that you're able to demonstrate to your caregivers, your parents or otherwise, that you are at that point where you can take responsibility. When your parents or caregivers are ready, can sometimes be a little bit more tricky. It's often very hard to have a sick or an unwell child at any point in time. So even when you're well, there is a tendency for some parents, and I'm no exclusion from this, to wrap their children in cotton wool and want to look after them and protect them always. We have to accept as parents that as you get older, so you take greater responsibility, and we need to give you that responsibility. We need to recognise that you're the one with this condition, not us. You have to make those decisions. And we also want to have that opportunity as doctors to have you come in and visit with us and to sit down and have an appointment that is just you, and then have at other times appointments where your parents can join you. There may be things that you want to discuss with your doctor that is, that you don't want mum and dad to hear, and as you're getting older, that's a very appropriate step to take. We also want your parents to encourage that independence and encourage that separation, I suppose, from the visits with them. Importantly too, we need parents to take on that responsibility and that support role in the household of you taking responsibility for your condition. So the occasional gentle reminder to take your medications may be a good thing if it enables you to keep on track and to step up to that responsibility. When your condition is ready is a little bit trickier. Ideally, what we would like to do is transfer your care and transition you over to the adult clinic when everything is stable, when you're in a state of being well, preferably not when you're in the middle of a big flare-up or when we're having to make major changes to your therapy. We don't want things to slip through the cracks, so to speak. We want the adult doctors to be able to pick up where we hand over and run with things as though there was no change in care at all. There are always little things that will need clarification. And unfortunately, because these diseases are somewhat independent of our decision process, it doesn't always work out the way we plan it. So sometimes we are in a position where we have to transfer despite the fact that things are going, but we do the best we can. As far as when we're ready, we like you, we don't want to necessarily hand you over, but we certainly have rules that we have to follow by as well. At 17 years of age, technically speaking, you come under the adult service of the hospital services in Alberta Health. There is a little bit of grey zone there. There is some room to move, but for the most part, once you've turned 17, most of the services that exist for young adults will then start to shift over to the adult hospital. Things like going to the emergency department. You may be expected to go to the adult emergency department in a lot of centres. What we try to do is have things in place prior to that. Clearly, if we're looking after you, there are some things that we will continue to do, beyond 17. But certainly by the time you're 18, you have to be within the adult service, the adult-oriented services. So it's important for us as the paediatric GI doctors to identify an adult IBD doctor who is in your area, wherever that may be it here or somewhere that you're going to go to school, and to identify them, make sure that someone is happy to take over your care and is going to be able to see you, fit you in to see their clinics. Then we organise for you to move across at a time before it gets difficult to get services in place for you in the hospitals, depending on your age.
So thanks, Dr. Carroll. I think that's a good summary for what I think patients should expect when they're be under the age of 18 and about to transfer. And just before I forget, there's actually going to be a time for questions. I don't know if you've joined us before in a broadcast, and so if you can just type in your questions, we're going to be happy to answer them. And we're going to do, the first part is going to be for the patients and then later on for physicians. And so just before we go to that, I'm just going to talk a little bit about what I want to talk about with patients when they come and see me and what we would expect of you. So the first thing, we'd actually want you to take responsibility for your care. And so that can be a difficult thing in some ways, first of all, for you to take that responsibility. But the second part would be also for your parents to give you the opportunity to take that responsibility. So in order for that to be possible, it's important that you actually know, do you have Crohn's? Do you have ulcerative colitis? Do you know where your disease is? Do you know what kind of medications you've been on and what medications you're taking currently? And so that's actually really important knowledge for you, because you may actually come to our clinic and I would get a nice letter from Dr. Carroll or Dr. Wynn about you. But in terms of, it's important if you're, as an adult, if you go to and see any kind of care provider, that you're able to provide that information to them so that you can receive the best care possible. The next thing, it's important for you to take responsibility for the appointments that you have. And so we all know that life changes and you've had booked an appointment 6 months in advance sometimes. If you're not able to make it, you should actually call and just change that appointment. It's not your parents' responsibility, it's your responsibility. And so we would actually expect that you would be the one that would contact our office and make those changes yourself, or else just come to your appointment, which would be the ideal. The next thing is that something that's called adherence. Adherence is something where we say when you take your medicines as they've been directed. And so we want you to, the best way for you to stay well is for you to do the things and take the medicines that we've talked about that have been prescribed by the pediatric IBD specialist and then also by myself as you transfer. The next thing, in order for you to know that you're taking responsibility, is that you have to know when you're flaring. So if your disease is actually normally in remission and then you get sick, it's important for you to know what those symptoms are for you being sick. For most patients, it's about belly pain or it's about diarrhea or bleeding, but people are a little bit different. And so often the big question is do you think your disease is flaring? Do you think you're being sick? And so if you're sick, the next thing is what are you going to do about it? When you're a kid, often you would tell your mom, and your parents or your dad would call us and actually make an appointment. But when you become an adult, it's important that you know how to talk about what your symptoms are and know who to call and what to do if you get sick. So the next thing is actually we want you to become independent, and part of that has to do with about taking an active role. So it's actually interesting when patients come, often for the first appointment to see me, they actually bring their parents with them. And I'm actually fine with people bringing their parents, because I think sometimes parents have to know that their kids are being taken care of in an appropriate manner and that they respect us. And though, however, at that appointment, we don't really want your parents to give the whole history. You know, maybe they give the history about when your grandma was diagnosed with, or that kind of family history stuff. But for the most part, you should understand what happened. And so part of what it is that's listening when your parents tell the story about you. It's also about you taking ownership about what your health story is and how it's been going for you. And so we'd expect that you would be the one that's asking the question and also answering the questions at that appointment. You know, your parents would also be allowed to ask questions, but I do want most of the questions to come from you. The next thing, it's actually probably one of the hard things that happens as you transfer from pediatrics to adults, is actually now it's your responsibility to pay for your medications. And so you may or may not have coverage through your parents. And so as you turn 18, some insurance plans actually would cover you, especially if you're going to school to post-secondary education, to university or college. But if you're not, if you're just working and you have a job, which is great, you have to know how you're going to pay for those medications. And so different plans have different kind of benefits. But the medications we prescribe can be very expensive, and it's important that you be able to cover them. And there are lots of support that you'd have in our clinic for helping you figure that out. But at the same time, it has to be an expectation that you would know that you need to pay for your medications. And the last thing I talk about, and it's one of the things, is that often when you see pediatric GI specialists, they might take care of things that are taken care of traditionally by a family doctor. But there's some other things that would happen as you become an adult that you would actually be responsible for seeing a family doctor for. So we wouldn't necessarily see you if you have a rash on your leg or if you have something else. It may or may not be related to your IBD, but it'd be important for you to have somebody else to see about those things. Then I want to talk a little bit about what you can expect from us. So you can actually expect that we'd treat you as an adult, that we'd actually want you to be involved in your care, and that we would treat you with respect, that you're a person that's able to make decisions for yourself, and that you're actually able to contribute and participate in your health. The next thing you can expect from us is that we'd actually work really hard to get you well and to keep you well, because we actually care about patients too, and we actually also want you to be well, and so we're willing to work really hard to help you, but we need that collaboration from you in order for that to be possible. Third thing that you can expect from us is that we would provide ongoing education. So over time, things can change. Your IBD can change. There might be new advances in IBD, or there's different medications that are available. And sometimes people just forget things that happen, so you can't remember all the stuff that you've been told, or over time there might be new things that we want to screen for. So your increased risk of cancer or things like that. And we actually want to talk to you about that over time. And so we're going to continue to educate you about your disease as you come through our clinic. And the last thing that is important for you to know that you can expect from us is that we're only going to speak to you. So your care is confidential. If you bring your parents to clinic, the fact that we talk in front of them would be, assumed that you actually understand that it's okay for them to know, but that we wouldn't provide information about you over the phone to your parents, because you're now an adult and you're now responsible for your own health care. So the next thing, I guess we just want to move towards questions, and I think there's a number of questions that are out there, and just think we're getting to them right now. So what would you say was one of the most important questions people ask you, Dr. Carroll, when they come to clinic and you're going to transfer them? Because I think you talked to a bunch of people about that even today.
Yeah, I did. So does it hurt? No, I'm just kidding. No, it's. I think the first thing they ask is generally, am I going to see the same person? So it's important to realise that when we transition to a clinic or to a new doctor, that we do try and maintain that continuity of care. So where different clinics will operate in different ways, and certainly some clinics may have a number of doctors, but people like to know that they're going to have a point of contact, that they're not going to be, left, felt abandoned or left in the lurch if something does go wrong. And so we try to make it clear that until things are set up with the adult clinic or with the adult GI doctor specifically, that they can always call us as well. They're not going to be left in the lurch, that there is a process where this care is transferred across, and that when they do establish themselves with adult care, that you also have a network of professionals there to help. There's your nurses, there's a lot of people that they can contact directly, and it's a matter of getting those contact numbers and contact names established. So I think that's probably, in my experience, people's greatest fear is that suddenly there's going to be this big gap and they're not going to have anyone to talk to if something goes wrong.
Yeah, and I have to say that in our clinic, we actually take a lot of patients in transition, And we do have several nurses that work with us. And it's actually really helpful because it's similar to the IBD nurses in the pediatric clinic. They're sometimes less intimidating to talk to, and you can talk to them a little sooner than you can often get in to have an appointment with us. So I think the next question I'm going to ask Dr. Wynn. So we said it's a process, but how many times would you see the adult GI before I stop seeing my peds GI? Is it I just see the peds GI one day and the next day I see the adult, or how does that actual transfer of care work?
Well, transition actually, it is as Dr. Carroll said, it's a process, and it depends on the model you use. I think often people will use a model where you see an adult gastroenterologist and a pediatric gastroenterologist at the same time for a few times before you do the final transition to the adult gastroenterology ward. I think for us, it is a very clean-cut transition where you actually see us and then straight away go to an adult. Once you've seen the adult gastroenterologist, your transition is complete. The reason I say it's a process is because it takes a lot of education to actually prepare a patient to be ready. So like yourself, prepare for transfer to an adult. So transition is the transfer of care just one time in the whole transition process. So, so I think it depends on the model. It may well be that you don't see us together at all. You may just see the pediatric gastroenterologist in one appointment and we say goodbye to you. And then we obviously continue to take care of you until the day you see the adult gastroenterologist. But once you've seen the adult gastroenterologist, Dr. Croker, then she will take over your care from that day onward. Whereas the day before, even if you run into a problem, then of course you have to contact us because obviously Dr. Croker, for example, would not know all your history at that point because she hasn't seen you yet. So we like to make sure that transition is a very clean-cut process. There's no bridging between, the two physicians because that can create a lot of confusions.
Yeah, I agree that it's actually important for us to know what the clean-cut process is, and so patients know who to call. And so until you've actually seen one of us in the adult clinic, it's actually important that you know that you can still call the pediatric team because they are going to be the ones that know you best. As soon as you come to your first intake appointment with us, we would actually take quite a bit of time actually with you and your parents to hear about your story and hear what everything you've been going on and make a plan for ongoing what we're going to do now and how we're going to treat you in the future.
I think too that point of the transfer of care versus the transition process is it's important we make a very clear distinction. That transfer of care where you stop going to the pediatric clinic and you go to the adult clinic, that is a single point in time. The transition process, we typically will start discussing transition age 13, 14, we're going to start expecting you from that point of view to have your medications under control and know the sorts of things that you're doing and asking those questions. That process may continue beyond 17, 18 even as need be for some people. But the actual transfer of care, how many times you see us versus the adult doctors, may be a very clean cut, and they're very different things.
I think that's an important distinction to make because I think it's very important for people to know exactly what that process is, but also who to call and that sort of thing. So I think we have another question out here. So maybe I actually take it myself since I'm a patient of 19 years of age with Crohn's disease, but I'm still living at home, but I'm having problems with my mom controlling my health issues. How can I manage that? So I have to say that's probably one of the greatest struggles that patients that are trying to grow up. So it's about everything probably. I bet your mother's trying to control other parts of your aspect, and that's just normal part of life, is that parents want to be involved, and yet parents also want you to be independent adults. And so I think part of that is a discussion that you have with your mother. When you're living under their roof, people often have rules that you're going to follow the rules in their house. But I think the one thing is that if you demonstrate to your parents that you actually can be trusted, that you will take your medications, that you will go to the appointments, and you just talk to her about what's going on and ask her to respect that ability of you to take care of yourself, then I think she'll be able to back off. But I think what it is it's a process. It's not like one day she helps you with everything and the next day it's you're completely responsible. We often talk about how the change in responsibility is gradual. So gradually your parents, when you're a child, if you're 5, your parents are completely responsible. When you're 12 or 13, you're starting to take on responsibility. And when you're 17 and you get transferred over to our healthcare, you actually might be 70% in charge and your parents are 30, But people are different. Other kids, actually, their parents are like only 30% involved and 70% would all be for you. And so I think it's actually really important to know that people are unique and that transition process actually takes time and is actually individualized to some degree about how long you've had the diagnosis, how stable it's been, how sick you've been, and really about when you were diagnosed. If you're diagnosed at 12, you have many years to think about transferring over to the adult clinic. But if you're diagnosed at 16, this all might be relatively new for you, which is why some of that extra transition stuff might be done more in the adult side just because of the age group. So next, I guess we'll go over
Just wanted to make a quick comment. I'm glad that you asked that question. I think the fact that you asked that question actually reflect that you are actually developing some independence, right? So it's good that you asked that question, because I think just knowing to ask that question, it's very likely you already have that solution.
And I think the one thing to remember is that sometimes it's actually harder for your parents to give up that responsibility than it is for you to take it on. But they actually, once they realize that you're capable of it, I think they're happy to give it to you. But if you aren't taking your medicines all the time, or if you're not showing up to appointments and they're getting messages on their home phone where you live that you didn't show up, then they start to worry that you're not ready enough to take control of your health. So the next question is about Humira. I don't know if you could answer this question, Dr. Carroll. My son is on Humira, and I've been giving his injections for years. He is turning 18, but now he's reluctant to give the injections himself. Any advice?
Well, it's a tough one, that one, because I can understand lots of people don't feel like giving themselves injections. It's not the most pleasant aspect of looking after yourself, and it's certainly a lot more involved than taking a tablet. For some people, they will struggle with this issue forever, and there are adults who cannot, no matter how hard they try, give themselves injections. That is not the end of the world. We have home nurses and other services that, when necessary, can help with that. The fact that mum's giving you injections now, and that works, that doesn't prevent you from taking on responsibility of your own healthcare. She's just providing, a service as a nurse would in that respect. What's important is that you start to be appreciative of the things that are going on, that you, as Dr. Croker said, that you're turning up to your appointments, that you're taking responsibility of your care in other aspects. In due course, if you manage to, get on with giving your own injections with support from the nursing services that can give you tricks as to how to do it, eventually you may get there. And if not, then there are times where potentially home nursing services, if you've moved out of home, may need to step in. A lot of the time, it's not just about being 18 that allows you to get to injecting yourself and being totally independent. This isn't just one day you wake up and you're in control of everything. We get there in time, and sometimes little steps in the right direction are the most important positive moves we can make.
Well, I think that's an important point to remember, is that there is adult patients where their spouse might give it to them, or somebody else, or sometimes they actually go, either they have the injection nurse come to their home and help teach them how to do it, or do it for them. And then there's some pharmacies that also provide that injection for you, where you can just go to the pharmacy and they'll do that injection for you. And so that process, probably part of what it is it's more important that your son is actually taking responsibility to remember that it's time to take his Humira, how in which he gives the needle, whether it's you or if it's at the pharmacy or one of the nurses, that's actually it's not as important. And so I can see how anybody would be reluctant to inject themselves, but often once they realize they can, it gives them a freedom to know they can manage their own care.
Reluctant doesn't mean incapable either. I mean, I'm sure when you first started having to inject your son, it was probably not something that you were very keen on. Having to do that to your child is not an easy step, but you learn how to do it. You manage to overcome your own fears and concerns, and perhaps the limitations that were faced. And we need to support young people to take those same steps. It's not a natural process to inject yourself, I don't think, personally, so it does take time.
I think the important thing as well is to make sure that you actually inject properly. So if there is a fear of injecting the medication, you may get it wrong. So it's important you're well trained to do it. And in fact, all the medication get into the tissue rather than leaking around the needle. So if you were to make sure that your son do it well, and make sure you watch him do it well at least a few times before letting him do it himself.
Well, I think the one thing to remember about the Humira needles is that there's two forms. There's the self-injectors as well as there's a needle. And so different people would do better with different types, and it's important to talk to us about the types that are available for you so that you can actually pick the one that's easiest for yourself. So I think we're just going to move on to the next thing. It's a little bit about becoming independent. And so I think I'll ask Dr. Wynn this question. I'm moving away from home for school, but I don't know how to handle living with other people, rooming with friends in the dormitory, having washroom access. And how do I request this? And do I have to tell them I have Crohn's disease? And I think maybe tell them might mean the friends, or it might mean like, you mean the school. Any thoughts on this?
Actually, there's a number of questions on the screen. I'm confused as to which one it is. So I think it's the second question,
Yes.
right?
So it's about how you would handle things as you go away to school. Do you have to tell your friends, or do you have to tell the school that you have Crohn's disease, or is that your own personal information?
I think it's really a personal choice, but I think overall it is a good idea for people to know that you have a medical condition, because, you know, in any emergency, you know, it's, I think, particularly when you take a medication, for example, you react to it and people have no idea what you have, then it'd be a disaster that it took a while for those information to trickle through. So I think clearly you need to sort of establish enough of a relationship with whoever you're living with to know that these can be kept confidential. And then after that, I think it's important for some of your friends to know. And certainly, if you're living in a dorm, certainly I think it's important that the people who are managing that place know about your condition as well. And I think it's also important for them to know your condition, particularly for access to a bathroom and things like that. I think a lot of the dormitory would have places that are close to the bathroom. So particularly if your disease is not well controlled, that it is important that you have access to this sort of facility fairly quickly. So yes, I'm for sure, make sure you look into all aspects of your accommodations to ensure that you have a smooth relocation.
Yeah, I think the one thing that's also important to remember is that if you require a note from either yourselves or from myself in order to access those resources, we're happy to provide those letters, because we know how important it is, and important for you to have the right stuff available for you. And I think some of it might be in terms of just location of your room near the washroom if they don't have private washrooms. And so there's lots of things to look at. And it might also I've written letters also for people that have more dietary restrictions. It's people with celiac disease and things. And so sometimes it's not actually a good idea for them to be a part of the meal plan for their dormitory, but sometimes those are considered mandatory, but within medical reasons, sometimes those can be excused. And so I think it's important to talk to us about what you're facing, but also to plan ahead and think about tour the facilities to see where you'd be staying. Just like if you're going to rent an apartment, you don't kind of want to rent sight unseen. You want to go check it out beforehand.
Probably also important to mention too that your parents have done this for you along the way. They've spoken to your teachers at school sometimes. They've had to speak to people who are going to school camps. They've had to, set up things within exam situations so that you've got access to the washrooms. So these things have been happening. The fact that you're now the person thinking about that is a really clear indication that you're taking that responsibility. But also the fact that this is about what makes life easy for you. How do you cope in a day-to-day existence? You don't have to tell anybody that you've got Crohn's disease. In some instances, it's important that you do, and that is a choice that you have to make. But we're here to help. The clinics are here to help. Most of the university services are there to provide assistance to people who need it. But if you don't ask for that help, it's very hard to provide it. So making that decision about who you tell is also part of making a decision about what help you think you need. And it's okay to speak to us. It's okay to speak to your parents still. Just because you've transitioned does not mean you can't ask them for advice.
So I think I'm just going to do one last question before we move to the other section. And this is, how do I coordinate the transfer of my care to adult GI? I'm supposed to be moving away for work or school and in September, and I'm going to see them soon. Should I ask them to see a new adult GI where I'm going to be studying? And so I think I'll take this question because I get asked this often. And so I think the most important thing, it kind of depends on the type of care that you're needing. So it depends on the medications you're on, and it depends on how much you have a home base still in Edmonton. And so if you still are going to come home at Christmas time and see your parents, or you're going to you're going to be coming back periodically, living here permanently, sometimes we make a decision depending on how sick you are, whether or not you actually need to be transferred formally at the time in so that when you go to school, whereas you don't. So if you're on medications like Remicade or that require you to actually get infused in a place of a different province, it might be more important for us to have a physician there that would follow you so that they would know about you in those infusion clinics. If you're on medications like sulfasalazine or Salifolk or even Imuran, then there's actually ways often for us to follow you when you live in another place. So it kind of depends. And so I think it's really important that you're thinking about it and that we actually can talk about it at the appointment so we can make a plan. And so I often plan to see patients when they're going away to university. I'll see them when they get back in the fall, in the spring, and then again right before they leave at school, just to make sure that before they go back, they're actually well. Because if you're sick, you're more likely to require services there. But if your disease is perfectly in remission, and I might not only see you every 8 months, it might be important for us to just to follow you closely from that perspective. If you do flare while you're away and we haven't transferred your care, it's important that you could still call us and direct you about where you could go, and we could possibly get you into a physician that we know that lives in your area where you're going to school, which we'd actually be happy to facilitate that because we know that it's actually can be difficult to get in sometimes.
This is also where having a family doctor comes in. I mean, most of the universities have health services. You will be able to find a family physician or a general practitioner on the campus or nearby. It's important that you do establish a relationship with them. They can always pick up the phone and speak to the doctors back home, wherever your primary care is. If something happens and you need to get something done quickly, you want to have a relationship with some health professional in the region you're in, not only because of your IBD, but also because other things will happen. I mean, you may need to get vaccinations to travel. You may need to have a pap smear done. You may need to have other health things taken care of whilst you're away from home, like during the school term. And that is where the local doctors come in, and they can always get advice where needed and help administer care regarding your IBD by remote control from the adult clinic. So it's important to have that in place when you get to school.
Yeah, and I think those student health services is actually a really important place to get access to care because they know there's lots of patients like yourself with chronic illnesses that are only going to be living there for 4 to 8 months, and so they know that's the people they're going to help. So I think we're going to move now to the next portion of our talk, where we're going to talk about about our little focus on the for the physicians. Patients, you're welcome to stay on and listen, although hopefully you'll understand most of what we have to talk about. I think it'll still be beneficial for you. So Dr. Wynn, I'm just going to turn it over to you to talk about transition from pediatric to adult for the physician.
Thank you, Dr. Croker. And thanks again for inviting us to this webinar. I think this is the first time we've done this. It is really a privilege for us to be here, and also thank you for tuning in to this beautiful Edmonton afternoon. So I think we need to sort of understand transition from a historical background. I think because for many years in pediatrics, we weren't able to transition patient because our patient actually doesn't live that long to be transitioned, really. So I see transition as a celebration. Being able to transition our patient to adult care is, in fact, a success story for us. And if you look at people with cystic fibrosis in the past, or even some of the patients with Crohn's disease, ulcerative colitis, they often die young, right, when they were diagnosed. So to be able to transition our patient to adult care, I think we need to celebrate that event. And transition, thank goodness, it happened to all adolescents. And not just limit to patients who have chronic diseases. It's happened to everyone. And we all go through transition, even for patients who are totally well. And I think many of us face the same issues. But particularly for those who have chronic disease, it is unfortunately often happen suddenly and haphazardly. And this is partly because of our healthcare system, where they demand for us to transition patient at a certain age. For example, at 17, 17 and one day you have to go to an adult care, whereas 16 and 264 days you go to pediatric. Unfortunately, transition doesn't happen that way because it is, as I mentioned later on, it is a process. And one of the big issues is often patients who have been looked after by pediatrician or like ourselves may not have primary health care for many years. So they may not have a family physician, or they may have a pediatrician. They haven't seen a pediatrician for a long time, right? Because we do look after a lot of their issues for many years. So it's important that we actually get a family physician involved. And some of these patients who, often also lost the follow-up. We have patients that reach 16, 17, decide not to come and see us. And we don't have a good tracking system in place. We have no idea that they haven't been seeing us. And of course, if they haven't been seeing us, we can't actually plan for transition. And guess what happened to them? They're going to relapse when they're 18 or 19 and end up showing up to the emergency department, and then transition happen in that place, which is forced transition, really. Some of the pitfall of the current transition system is often like pediatricians like to keep their patients. And again, I have to emphasize, it is a celebration. I think we shouldn't have this mindset that, if you look at this patient, we should keep them as long as we can. I mean, I think we have to make up our mind that when we think they're ready to be transitioned, they should be transitioned. We should avoid abrupt transition and making sure that our patient doesn't leave medical follow-up and supervision. What are some of the potential problems in transitions? So a lot of our patients have this apprehension in seeing, because particularly if they've seen a pediatric gastroenterologist for 5, 10 years, now they have changed to a different setting, different clinic, different physicians, different set of nurses. So there's this apprehension and uncertainty about the change. And of course, there is a different style of practice between our adult colleagues and ourselves. And it's important for us to understand what we transition our patient to make sure that we prepare our patient well for that. And of course, there's always conflict in terms of the change in the therapy that we give. And one would advise is for us not to really make sudden changes in medical treatment when we during the transition phase. So the Society for Adolescent Medicine defined transition as a purposeful planned movement of adolescent and young adult with chronic physical and medical condition from child-centered to an adult-oriented healthcare system. So it is an intentional transition of care from one set of physicians to another set of physicians. Like I said earlier, it is a process, not an event. It has to be planned over time. And that process could be 6 months, or could be 5 years. It really depends on when we actually diagnose a patient, for example, inflammatory bowel disease. We have diagnosed you at, say, age 10. We have much more time to prepare you for transition rather than diagnose you at the age of 16 and a half. We don't really have a lot of time for transition. Hopefully, ideally, it should be an individualized planned transition and implemented in stages. So, because different patients have different needs. So, ideally, that should be the case. And the time of transition, unfortunately, dictated in Alberta by the age, which is not the ideal way of determining timing of transition. Ideally, the time of transition be determined, so firstly, by the disease itself. We'll make sure that we transition our patient in a stable condition rather than in a very unstable situation. We transition them when they physically and also psychologically ready. That's the ideal situation. So how do we actually achieve successful transition? And I see transition, preparing patient for transition like parenting. So you should be a coach or a teacher rather than being overprotective. So to promote successful transition, I think it is important that we provide appropriate expectation for our patient. And those expectations hopefully will achieve personal responsibility and facilitate development of coping strategies. There's the tendency for many parents to protect their children or guard their children from sort of harm and suffering. So they become overprotective, but inadvertently they actually hinder the development in coping with their illness and accepting their own responsibilities. And unfortunately, that will make them sort of incompetent. So this slide really to try to illustrate that transition is a process. It's a continuum. It's for a child from becoming totally dependent on you as a parent to becoming independent. So I think that's why I think preparing a child for transition it's important that we intervene them at different stages in their development. So for a primary healthcare person or for any physician looking after children with inflammatory bowel disease is that we need to prepare them. We have to ask them specific expectation. We need to educate them about the disease and the medication age appropriately. And we need to teach them appropriate skills. For example, how to actually advocate for their care, how to actually coordinate their care. Simple things like how to come to an appointment, organize an appointment, how to get the medication, that sort of thing. These are important skills that need to establish over time. And often I try to see the patient by themselves at 15, 16, making sure they are able to give the history and the medication to me. And hopefully they are able to do that on their own when they transition to an adult physician. So for primary physician, I think the expectation for you to help us with that process and to really educate them, because I think transition is really an education process. If you can help us in educating and supporting and ensuring that they go from someone who is quite dependent on their parent to someone who can become an independent thinker. So that's really the key point that we need to take away from this session. There are a number of determinants of successful transitions. I think for some patients, it doesn't matter what you do, they will be a successful transition to adult because they are very competent. But there are other patients who are significant family dynamic issues, where the family, for example, if the mother is too protective, for example, that will hinder transition, where there may be inadequate support systems, where healthcare provider is not really ready to transitions, and cultural differences as well. We have family who have different cultural background, doesn't really see independence at the age of 18 is ideal. Some of them see their kids, at 25 being sort of more an adult. So I think transition need to be organized, and it has to be purposeful and need to be planned for. I think I finished there.
I think that's it. Thank you, Dr. Nguyen. And so I think I'm just going to talk a little bit about what we would do for what the adult GI expectations are for the physicians and the primary care doctors that are involved in the care. So I just wanted to bring us back to that whole point where our goal is to provide a continuum of care, and yet there's a point in time where we actually do transfer care. And so in terms of the importance, it's important for us people to understand the scope of adult GI care. And so I think when in pediatric GI care, there's actually a lot of emphasis on growth and development because it's GI, and that's partly what they do. And so the care that we provide is limited usually to IBD specific issues. And so there's lots of other issues that patients can have, and that we usually don't manage those things. And I think that's one of the things why often children that are seen in pediatrics don't have a family doctor, is because often those issues are managed by the pediatric GI, who are pediatricians first and then become gastroenterologists afterwards. And so I think what it is that, so we want to emphasize that patients will still require standard of care. And then the other thing is that if you only care for or you're a pediatrician, you'd actually want to transfer them to a family practice physician, and so that they actually know that there's the two different types of care and that it's different. And I think the one other thing is that we want to have good communication between us, so that we all know when the transition is happening, what's going on with the patients, and so that we have good communication back and forth about what the care is about. The next thing is that I want to say, what can you as a family doctor expect from us? We will always accept transition of the adolescents with IBD from our pediatric colleagues. I think that's an expectation that you can say for sure, is that we know that this is a chronic illness that is complex and it's difficult to manage even for us sometimes. And so we're always happy to take them on in care. And so sometimes they might have, if you think that they didn't see their pediatric GI for a number of years before they get transitioned, if they get to the age and you're like, I have a 19-year-old with Crohn's disease, even if they're stable, it's fair for them to connect them with one of us so that we can see them on a non-urgent basis and make sure that their care everything's being cared for. And I think it's almost another way in which it makes it non-urgent, because if they get really sick and they go to an emergency room and they're very unwell, it actually just expedites it, makes it a little more traumatic for them. The other thing you can expect from us is that we'll always communicate back to you with letters and communication about what's going on with our IBD and investigations that we're doing. And so we always like to copy you on things because we actually know that you're responsible for the overall care, but we actually, so we'll always be communicating with you. And the other thing is that you got to know we're available to provide IBD-specific advice. So patients for flares, for assessment, for transfer of care. And so say somebody has IBD and they're, people in Alberta tend to move a lot. Not everybody moves to Alberta, but people move away. And so we're actually happy to find them another GI specialist in another part of the country or province that could care for them if they move. So I think that pretty much sums what we were going to talk about today. So I think we want to move to some questions from the audience. And so I think the one's a good one for the top. So maybe Dr. Carroll, you can answer this one. I'm a family doctor in a small community with an adult gastroenterologist who sees many of my IBD patients. Do I need to refer all my teenage patients that I'm concerned about IBD to the Stollery, or can I refer them to the adult gastroenterologist? Many of my patients, as we know, in Alberta or in Canada, because it's so vast, that have some difficulty traveling to Edmonton. So what would be your advice to this family doc?
I think that's an excellent question, and it's a conundrum that a lot of family physicians and paediatricians as well are often faced with. In more remote communities, there often aren't a plethora of specialists that you can rely on. So in some instances, what we do here is we work as a team. We have to have the right facilities and the right information, the right care available for the child or for the young person. In some instances, it's going to be quite reasonable probably for an adult gastroenterologist who has an interest in IBD to see an adolescent patient. If they're 17 or 16 and a half, 17, this is a new diagnosis and they're a fairly mature 16 and a half, 17-year-old, then it may be reasonable to discuss that with your adult IBD or adult gastroenterologist in town. On the other hand, if you've got a 15-year-old or a 14-year-old, particularly someone who's growth retarded, who has delayed puberty, who has secondary delay or arrest of their pubertal development, someone who's pre-pubertal despite their age, those things are things that, as paediatrician and as paediatric gastroenterologists, particularly with IBD, we're used to managing. It's not the focus, nor is it for the most part the training of adult gastroenterology to focus on those issues. And there's a number of different things. That's not to say that adult gastroenterologists aren't capable of managing those things, but they're often not resourced to do so. Our clinics are set up with a different focus. We have our dietitians with us at all times. We have our nurses who are geared towards addressing a lot of those issues. And our background in terms of child development and physiological as well as psychological development is to focus on those things. So I think if there's a question about that, the best thing to do is to discuss it with us. And then as a team, we can look at the best person to manage it. I've had patients from very far away where, because of distance being the tyranny, I've seen them made management plans, but then in connection with family doctors, paediatricians, and at times adult gastroenterology colleagues in those places, we've shared the care along the way, because there are things that we're all probably more, have individual expertise at. I think the point is that whatever's going on for the child, whatever the child's nor the adolescent's needs are, they need to be best met by the decisions we make. And working as a team is really the only way we're going to get to that on a reliable and regular basis.
So yeah, so it sounds like there's like a lot of differences, and so it kind of depends on how sick they are. It kind of depends on the age of the patient. And so I think sometimes I agree that one-time assessment and then ongoing direction might be helpful. And I think even by calling you guys up on the phone and reviewing blood work and things like that, it would be important for us to understand whether or not they need to come down. I think there is some resources for people that have some difficulty traveling, and that's one of the things that you could talk to either the pediatric or whatever. So there is funding for people to come, especially if they really need to be seen. And so I think it's difficult for people to travel into Edmonton sometimes, but I think the Stollery wants to provide the best care for children in northern Alberta, and I think that's their catchment area. And so I think it's fair for them to be seen. I think people are doing a great job, and it's actually better to be reassured than to find out that you missed that growth option. And so I think one of the most important things that children often want to know is how tall I'm going to get. And I think there's only a limited time in our life where you can actually grow. And so if you miss that window, people can actually feel like they've missed out on things. And so I think that's important.
It's also very important that the adult gastroenterologists that you're working in concert with, that you've discussed with them what their comfort zone is. I mean, sometimes people accept patients because they feel that there's not another option. But an adult gastroenterologist, I mean, there are lots of people I know who really don't feel comfortable looking after young people under the age of 16. 16, 17 is a bit of a watershed. As we've discussed today on the show, that's when transition to adult service is occurring. Certain funding structures are in place to look after 17 years plus outside of the children's oriented services within Alberta Health. So there is a process there, that there are support services. If you've got an adult GI doctor who's really uncomfortable looking after patients under 16 or under 15, then it's probably more appropriate in that situation that we are involved a bit more directly, or that we can provide at least an external support to the local services.
For the Stowell Children's Hospital, we at all time have a pediatric gastroenterologist on call. So they can always call the switchboard and discuss with the pediatric gastroenterologist on call. And if appropriate, they will discuss with one of us, one of the inflammatory bowel disease doctors. So I think it's because you really have to look at the context of the patient, right? And after discussion, I think you get a much clearer pictures of what needs to be done, I think.
And even like by reviewing the blood work in net care and things like that, that actually helps determine how sick they are. I think that brings us to the next question I want to ask Dr. Wynn. So what special lab tests or imaging would you want them to order for an adolescent patient to work up for possible IBD before they refer to you? And they asked, is it similar to what we've described before for adult referrals? So the stuff we always expect is a CBC and a CRP and some like basic stuff, but not anything too specific. So what would you want?
I think it's very similar to us as well, because I think a lot of inflammatory bowel disease patients have a mild degree of iron deficiency anemia, so you expect a CBC. They often raise inflammatory markers, so we often order an ESR and CRP. An albumin is something we like to know, because obviously that's a reflection of their nutrition. And whether in fact, and we often ask for some liver function tests as well, just to make sure that they don't have associated liver disease. If you're concerned about inflammatory bowel disease in this particular patient. That would probably be all we order. I mean, there's a bunch of other sort of blood work we normally order from a nutritional point of view, but I think at a diagnostic stage, a CBC, ESR, CRP, a liver function, and albumin is probably all I order at that point. In terms of imaging, I think for children, I think we like ultrasound better than sort of invasive CT scan because of the exposure to radiation. So, and we know that a barium follow-through doesn't really detect inflammatory bowel disease as well as, say, an MR enterography or MRE. So I think, depend on your access. I think ultrasound access is pretty easy, whereas MR access is a lot harder for family physicians or primary physicians. So, but those are some of the tests that I would order.
I guess the other thing to always include in the referral would be the family history. Like if they have a sibling with it or a parent with it, it actually would change your suspicion for the disease.
Yeah.
And then the iron studies again. I think you talked about the CBC, but I think often the iron stuff. So as we've probably talked before, is that a young male should never be iron deficient.
Yeah.
And so it'd actually be really important. And so that's actually a really red flag to know that you should be referring a adolescent male. If he's iron deficient, that's a worrisome feature for us always.
Yeah. And for kids, particularly, it's sometimes difficult to, it's not, an inflammatory bowel disease presentation in children can be quite different from an adult. A lot of adults would have diarrhea, abdominal pain. A lot of our kids, all they have is iron deficiency anemia, and that's it. So they present very similar to some of our celiac patients. So.
And what about the growth curve or whatever?
And of course, the iron deficient, and then they don't grow very well, right, nutritionally. So if you're someone who iron deficient and don't grow well, we need to look for the cause.
Depending on the circumstances of their presenting symptoms, I think the celiac screen is another important one. As you said, some of these conditions will mimic things like celiac disease, and it's more common than inflammatory bowel disease. So naturally we're going to pick up some people. If it's bloody diarrhea and these sorts of things, and that's obviously not going to be celiac disease, but where it's non-specific weight loss or lack of appetite or maybe iron deficiency anemia, having the celiac screen as a baseline investigation is often very helpful too.
Okay. So I guess the next thing, well, one more question is, pediatrics used to manage my patients' other things such as rash, etc. In your talk, you said that they should transition, they should go back to their family doctor. When they come to this, would you give advice from you guys to see whether or not who else should be seeing them? So I guess the rashes, we're assuming that they're non-IBD rashes, so not erythema nodosum or pyoderma. So what would you advise in your letter?
Is that this one? I'll take my dermatologist hat off.
So it's really dependent on your comfort level, I think. I have to say though, when it comes to rash, particularly when it's not obvious, I will refer to our dermatologist at a drop of a hat, really. So particularly for our patients who are on biologics, because some of these rash can be a bit tricky to know what they are. Some of them could be, fungal infections and or reaction, right? So I really rely on our specialists to do that. So rash is not as straightforward, I think. I mean, in general, even though we say we manage a lot of the other sort of condition of our that are not related to IBD, I think we do try to rely on our pediatrician in managing some of the sort of non-IBD related health issues. So we don't look after everything.
It's fair to say probably too that rashes occur commonly in children. I mean, they might occur because of viral illnesses, they might occur because of certain allergies. As time goes by, you see less and less of those as part of general infections and general viral illnesses. So what we're seeing as paediatricians, what we're comfortable in managing, and it may be very different to the sorts of things you're likely to encounter as an adult patient. In that situation, I think, again, it's important that if there's an established diagnosis or if there's an existing rash that's gone on for a long time, we may be able to suggest appropriate referral. But if something else comes up at a later time, that's when you need to be seeking the assistance of people with, within the adult service with expertise. And that may be your family doctor or it may be a dermatologist. Depends on the circumstances, obviously.
Yeah, I think as adult GI, we often also refer back to dermatology, because I agree that rashes are something that they see all day, every day, and it's something that we're not the best at. And so I think as our session draws to a close, I think there's just a couple things I'm supposed to mention and thank AbbVie Canada for their unrestricted educational grant for supporting these sessions. And so they don't actually tell us what to say, fortunately, because I don't really like people to tell me what to say. But they have been very instrumental in helping these sessions come to pass. The other thing I wanted to mention is that on June 3rd, coming up next month, we're actually having an IBD transition education session, and both Dr. Nguyen and Dr. Carroll and myself and the nurses will be involved in a session where there's education about a 2-hour evening session about what's it mean to transition, and it's for both patients and their parents. And so we actually hope that you'd be able to come out. If you haven't heard about this, you can actually go onto our website, www.ibdclinic.ca, and that actually will give more information. Our session next month in June is actually on pregnancy and IBD, so hopefully it's not too many of the pediatric people that have turned in today that are going to be interested in that session, but you just never know, planning for the future. I'm sure their parents won't be too excited about that if they're under 18. But I just want to say thanks again to Dr. Carroll and Dr. Nguyen for this session today.
Thanks for having us again.
Great.